So I also want to make sure that these patients don't have an underlying eating disorder. I want to make sure that I understand if there's any sabotage that's a potential here. Now, community that I deal with, which is good 80% urban, 60% African American, the concept of being thick is appropriate. That everybody wants to be thick, but thick does not necessarily mean metabolically healthy, and it certainly doesn't mean of appropriate body weight. And so there's sometimes a sabotage that occurs from the family. And the family or the husband or the other party may not want their partner to get thinner. They may feel that they're getting too much attention. They may feel that that person may leave them. So there's that sabotage I have to worry about. And the best way to handle that kind of sabotage is to engage the whole family wherever I can. Sometimes I'll bring the family in to have a conversation rather than just say, okay, well, here's what you need to do. Good luck and Godspeed. I find out that, hey, hold on, we're going to have to do something to bring everybody on board. And so sometimes I'll find out who the other members of the household are. And usually it's multi-generational. And then the questions I ask are typically directed of, if you're this way, tell me, how do the other people, how do they eat? What's their dietary intake? How healthy are they? Have they had high blood pressure? Have they had strokes? Have they had a heart attack? It opens up dynamic, and then it allows me to quickly determine if there's going to be a sabotage from that side. There's also the concept of self-sabotage. Nearly 40 to 60% of my patients have had some form of PTSD. And PTSD, especially in my female population, can be associated with a secondary development of obesity as a protective mechanism. Usually it's somebody who's been sexually assaulted when they're fairly young, and then that degree of assault has led to them using their body habitus as a protective mechanism so people don't pay attention to them. So they kind of meld into the back wall. And so that's something that sometimes I have to address right up front. Usually these are the patients, when I do my psychiatric history, they have significant anxiety, significant depression, and significant panic attacks. And then, usually they'll have other significant pain issues, and I can delve into that and broach the subject and have a conversation about that. There's also the guilt concept. Also then feels the family pressure and feels that there may be an economic loss. And there's a fear of change. There's also the inertia. There's also the fear that if I get healthy, am I going to lose my disability? I can't tell you how many patients I've had who are on chronic insulin therapy. And as long as they're on insulin therapy through the Veterans Administration and they're getting their insulin, they're disabled. And as soon as we get them off their insulin, they go, hold on, I'm not disabled anymore. I may lose some of my benefits. So those are the kind of things that self-sabotage has to be evaluated. Sleep hygiene we've touched on. I typically look at the patients and I give them the concept they're going to have to change habits. And in order to change habits, sometimes you have to have a new habit, you have to have a diversion or a distraction, you have to create new rituals. And because so much of what we do is cue related, and these habits are stacking. And so I get them to start thinking about that stacking change. I also advise them on doing a plan. Because if you just tell them to go, okay, this is what you got to do, and you don't give them a rescue plan, you don't explain to them how this is going to work out and what's going to happen, I find that it becomes a disaster. And so we talk very specifically about very limited meal prep. And I'm going to explain what I mean by that, but what I don't want them to do is to get overwhelmed with buying a keto cookbook with 365 recipes and trying to cook all of them. Because that's, at the end of the day, that's going to be food porn. And I'm going to talk about that later in this presentation. I want to use sensory specific satiety to get them to learn what being full is, to learn what an actual meal is, and not get confused by sensory specific satiety. And I also want them to have a pre-plan. And so I want to remove temptations. I want them to go through their cupboards and clean them out. I want to get rid of everything that doesn't belong. And I want to have emergency rescue plans. So if you're on the road and you can't function. Well, how are you going to do this? Well, you're going to have some hard-boiled eggs and you're going to keep them in a sack, and you can do that. If you are stuck eating at a fast food restaurant, you're going to take the bun off the hamburger and you're going to eat 4 patties or 3 patties till you have sensory specific satiety. There are certain times that pica is your friend. I mean, you can have ice and lemon juice on it, and that may give you a quench that you couldn't get in some other way. So I also talk to them about the fact that they're biological symptoms. They're not mechanical symptoms. So explain to them how, just like you fly a plane, it's off course 99% of the time. You're constantly making micro adjustments. So the autopilot is set, but every couple of minutes it makes another adjustment because the wind blows the plane off of direction. There's a whole host of factors that constantly blow the plane off direction. So don't expect that you're going to have a nice glide path that says, oh, my weight's going to go from 355 to 354 to 353 to, and all the way down to my ideal body weight. It doesn't work like that. There's going to be plateaus, there's going to be ups, there's going to be downs. They're biological symptoms and they're not mechanical symptoms. This isn't a gear that we're shifting. And for that reason, I try to reduce the frequency of weight measurement. I don't want them measuring weight every single day because it only pisses them off. One day they lost 3 or 4 pounds and the next day they went up 5. And then they lost 3, and then they went down 7. I'd rather have them do less frequency of weight measurement, but I don't want them to be completely away from measurement. So where I can, I try to gamify things, and I get them, if I can, I get them a CGM. Not all patients can get CGMs. When I can, I try to get them to measure blood glucose. Where I can, I try to get them to understand how ketones work. My ideal is to use blood ketones over urine or exhaled. I find that blood ketones are the most accurate. Where I can, I have them do blood pressure and EKG monitoring. I want them to see the blood pressure trend as they bring their weight down and as they get rid of their sugars. And they have, as part of my pre-intake, I explain to them it's the sugar that is going to hold the water, which is going to pull the sodium in. But once you get rid of the sugar, then you're not going to have the water, and your sodium is also going to leave. So you may have to take extra sodium. You may have to take extra salt. So those are kind of the things that we work on. So we also talk about cheat meals. And I don't want them to go from having a cheat meal to a cheat day and then end up with a cheat week and then just cheat all the time. And so the reason why we do cheat meals is, and that's every once in a while, is for them to maintain a high degree of insulin variability. And I also find that if they have that reward to look forward to, it's kind of a concept of harm reduction. Same as when we give somebody Suboxone, if they're an opiate addict, quenches a desire for them. My main goal is to avoid the processed food. My main goal is for them to avoid the vegetable oil. And if they're eating whole real food and they misbehave a little bit using whole real food, at the end of the day, metabolics are still going to be pretty good. I certainly will talk to them about their anxiety and their depression and their generalized wellness. And sometimes we'll recommend things like tyrosine if they're anhedonic. We'll recommend tryptophan supplementation if they just don't feel happy and if they're having issues with sleep. Sometimes we'll recommend GABA and explain to them what glutamate is and what it's found in food and how irritating that can be. A lot of times I will use topiramate, I'll use phentermine, I'll use some glutamide, I'll use metformin. Sometimes I am supplementing with testosterone, and sometimes I'm supplementing with thyroid hormone, but that's on the basis of their blood test. I'm not going to give somebody Ozempic who's not hemoglobin A1C greater than 5.7. I certainly would advocate, metformin may be useful even at lower hemoglobin A1Cs, and phentermine obviously is pertinent if their BMI is greater than 30. Topiramate and the combination of phentermine are beneficial. I'm very particular on presenting that information to my patients, and I have them have a separate signed consent just for the phentermine, the topiramate, and the Ozempic. I have individual consents just for those because there are some issues associated with them that we don't really know about. So I want them to know that they shouldn't get pregnant if they're on topiramate, that they may get kidney stones independent of everything just by being on topiramate. And so we have those separate signed and informed consents. There's a whole host of non medication methods as well. And those include infrared light therapy that I've already touched on. A lot of times we use hermetic drive, things like cryotherapy or sauna, to trigger growth hormone increase temporally. And those are sometimes good distractive methods assist in our metabolism restoration. Thank you.